Hello viewers, my name is Dr. Rajiv. Welcome to my education channel, YouTube Surgery and Orthopedic Education. Today's discussion is on hematopoietic bone tumors. The link of the previous first, second, third and fourth parts of the lecture series on bone tumors has been given in the description box. In the end, please subscribe to our channel and give us a like if you find the discussion useful. Also, please don't forget to press the bell icon below to get my videos regularly. The bone tumors are classified according to the tissue of origin or the matrix they produce. The rest are grouped by clinicopathologic features. The majority of benign and malignant primary bone tumors are cartilaginous, means they produce cartilage. Most primary bone tumors are benign. Metastatic tumors are more common than primary tumors. There are no benign bone tumors of hematopoietic origin. All are malignant. Malignant hematopoietic bone tumors include solitary plasmacytoma and multiple myeloma arising from plasma cells or lymphomas arising from lymphoid cells. Plasmacytoma is a rare plasma cell neoplasm of axial skeleton or soft tissues. The bone lesions tend to occur in the same locations as in multiple myeloma. Soft tissue lesions are often located in the lungs, oronasopharynx or nasal sinuses. It grows as solitary or multiple masses without evidence of systemic disease. Bone marrow biopsy and skeletal survey give negative results. Solitary plasmacytoma is the most common form of plasmacytoma. More than half of patients who present with a solitary plasmacytoma eventually go on to develop multiple myeloma. Solitary plasmacytoma has a better prognosis than multiple myeloma. Some patients have a considerable disease-free interval and a few remain continuously free of disease. Most cases of plasmacytomas cause paraproteinemia. Metastatic spread of plasmacytoma occurs to soft tissues frequently and occasionally to bones also. Plasmacytoma is treated with surgery, radiotherapy and chemotherapy as required. The etiology of plasmacytoma is unknown. Multiple myeloma is a malignant neoplasm of plasma cell origin. There is malignant proliferation of monoclonal plasma cells. There is increased production of plasma paraprotein and immunoglobulin, particularly IgG and IgA. Multiple myeloma is the most common primary malignant tumor of bone in adults. It should be suspected in all patients over 65 years of age with back pain and an ESR of more than 100 mm per hour. The neoplasm typically affects flat bones, that is, the pelvis, vertebrae, skull, and ribs. Long bone lesions are typically metaphyseal. Lesions begin in the medullary cavity, erode cancellous bone, and progressively destroy the bony cortex, often leading to pathological fractures. Pathological fractures are most common in the vertebral column, but they may occur in any affected bone. It produces classic punched out osteolytic lesions and generalized bone loss or osteopenia. The lesions are small and circumscribed. The bony tissue is replaced by tumor tissue. There is no reactive new bone formation. The lack of reactive bone formation is shown by the fact that most lesions are negative on bone scan. Microscopically, the tumor cells are round or oval with an eccentric nucleus and clumped chromatin, have a dense basophilic cytoplasm and a perinuclear clear zone containing Golgi apparatus. Other pathological features are flame cells, moat cells, Russell bodies in cytoplasm, Deucer bodies in nucleus, and rouleau formation in the blood smears. Plasma cell tumors are positive for CD138 and CD56. The cause of multiple myeloma is not known. Multiple myeloma has been seen with increased frequency in those exposed to the radiation of nuclear fallout in World War II. It has also been seen more commonly among farmers, woodworkers, leather workers, and those exposed to petroleum products. Some recurrent chromosomal alterations, such as hyperploidy, mainly trisomies, has been observed in half of the patients, as well as translocations involving the chromosome 14 in the remaining half. Interleukin 6 plays a role in the proliferation and survival of myeloma cells. It is an important growth factor for plasma cells. High serum levels of interleukin 6 are seen in patients with active disease and are associated with a poor prognosis. Adults above 40 years of age are usually affected. Males are affected more often than females. Usually, there is multiple site involvement. Common presenting complaint is worsening severe pain in the lumbar and thoracic regions. Pathological fractures of the vertebrae and ribs may result in acute symptoms. There is weakness and weight loss. Neurological symptoms appear if the tumor compresses the spinal cord or the spinal nerve roots. There is local tenderness over the affected bones. Complications include renal failure, susceptibility to infection, anemia, hypercalcemia, occasional clotting abnormalities, and manifestations of hyperviscosity. On plain X-ray, characteristically, there are multiple punched out lesions, usually 1 to 4 cm in diameter, in the skull and other flat bones. The skull shows a pepper pot appearance. Also, there is collapse of more than one vertebra, commonly in the thoracic spine. Diffuse severe rarefaction of bones and erosions of the borders of the ribs. Diagnosis can be made by finding monoclonal gammopathy on serum immunoelectrophoresis or elevated urinary and serum Benz-Jones proteins, that is, elevated serum BJP. Most myelomas are associated with more than 3 gram per deciliter of serum immunoglobulin and or more than 6 mg per deciliter of urine Benz-Jones protein. The most common monoclonal IgG or M protein is IgG, approximately in 55% of patients, followed by IgA approximately in 25% of cases. Bone marrow sampling from the sternum or iliac crest or a CT-guided needle biopsy from the vertebral lesion may reveal myeloma cells. End organ damage and disease severity are shown by low hemoglobin levels, very high ESR, compromised renal function, and elevated serum calcium. Also, there is increased total protein, reversed AG ratio, and normal alkaline phosphatase. The clinicopathologic CRAB criteria for diagnosis of multiple myeloma includes hypercalcemia, renal dysfunction, anemia, and bone lesions. The treatment of multiple myeloma is mainly chemotherapy for tumor control, radiotherapy for neurological compression, for localized painful lesions, and for soft tissue masses, and a splintage by brace for pain relief. Surgical treatment is only required for complications such as fracture and spinal cord compression. Lymphoma of the bone is a lymphoma that has originated within that bone itself, also known as primary lymphoma, or metastasized to a bone from another organ or tissue, that is secondary lymphoma. Secondary forms are much more common than the primary. Usual time of presentation is the 6th and 7th decades of life. The femur is the most common bone involved, followed by pelvis, spine, and ribs. Common complaints are localized pain or swelling and signs of nerve root or cord compression if the spine is involved. On radiographs, there is an ill-defined area of bone destruction in the diaphysis. A large portion of the bone or even the entire bone can be involved. Radiographs can be entirely normal, but extensive involvement of the medullary canal may be seen on bone scan or MRI. Therefore, lymphoma should be included in the differential diagnosis of a patient who has bone pain and an abnormal bone scan or MRI but normal radiographs. Whole body PET or CT scan is also useful for staging as well as for evaluation of response to treatment. Tumors are positive for lymphoid markers, reticulin positive, creatine negative and PAS negative on immunohistochemistry. Primary lymphoma of bone has a better prognosis than secondary lymphoma. The primary treatment of lymphoma is chemotherapy. Local tumor control usually is achieved with radiation therapy. Surgery is indicated for the treatment of impending or actual pathological fractures.